Okay, let's unpack this. We have this cultural script about surgery, right? It's always the climax of the movie. You've got the dramatic music, the bright lights,
Yeah.
the surgeon asking for the scalpel, and then, cut to black. The problem is fixed.
The triumphant score swells.
Exactly. You wake up, the credits roll, and you live happily ever after with your new bionic joint.
If only it were that simple.
Sure.
That's the fantasy.
Right. Because the reality is, the surgery is just the prologue, the actual story, the thriller, the drama, the high-stakes conflict. It all starts when the anesthesia wears off and they wheel you to the curb.
Specifically, it starts the moment you cross the threshold of your own front door. That's the real beginning.
Today, we are doing a deep dive into that exact moment. We're looking at the critical first day of home rehabilitation following a total knee arthroplasty, a knee replacement.
The TKA.
Our guide is a lecturer by physical therapist Ivan Zan, and he frames this initial assessment in a way that completely blew my mind. I always thought a physical therapist just came over to make you do leg lifts until you cried.
That's the stereotype, the drill sergeant in a polo shirt.
Yes, the no pain, no gain person.
Mm.
But Zan paints a picture that's so much more cerebral. He's not a drill sergeant at all. He's a detective.
A forensic investigator.
Yes, that's perfect. He's walking into a crime scene, or at least a potential crime scene, and he has about an hour to secure the perimeter, identify all the threats, and basically keep the victim alive.
It's a great analogy because the stakes really are that high. We aren't just talking about whether the knee bends a few extra degrees.
No.
We're talking about preventing falls, infections, blood clots, readmissions to the hospital. Zan is analyzing an entire ecosystem. He's looking at the architecture of the house, the chemical cocktail in the patient's blood, the psychological state of the family, and the microscopic healing of the tissue.
And if just one of those dominoes falls, the whole surgery can be considered a failure.
Absolutely. A fall can break a hip or loosen the new implant. An infection can mean another surgery. It's a house of cards.
So our mission today is to slow this process down. We're going to dissect the SOBP note, which I have to admit sounds like something you wash with, but is actually the framework for this whole investigation.
Subjective, objective, assessment, and plan. It's the skeleton of all medical documentation.
We're going to walk through the hidden death traps in a standard living room. And we're going to spend a lot of time on the why. Why is a simple throw rug a lethal weapon?
And why is a pillow under the knee, which feels so good to the patient, strictly forbidden? It's the cardinal sin of knee replacement recovery.
And just why that very first day, day one, is the most chaotic, time-consuming, and frankly dangerous part of the whole recovery process.
It sets the stage for everything that follows.
Okay, so let's start before the therapist even rings the doorbell. The pre-game investigation. Zan makes a huge point that he never walks into a house blind. He starts with the electronic medical record, the EMR. Now, to me, this just sounds like boring paperwork. Why is this so critical?
Think of the EMR as the mission dossier. If you're a spy going behind enemy lines, you don't just show up. You study the maps, the targets, the local contacts. Walking in without reading the EMR is like flying blind into a combat zone.
Okay, so what's the first thing you're looking for in that dossier?
The most immediate, the most critical piece of information are the rules of engagement, specifically weight-bearing status.
Meaning how much weight they're actually allowed to put on that new leg.
Precisely. And it's not a suggestion, it's a hard limit dictated by the surgeon. Imagine this scenario. You knock on the door, you're friendly, you walk in, you say, "Okay, Mr. Smith, let's stand up and walk to the kitchen."
Seems like a reasonable first step.
Right. But Mr. Smith stands up, puts his full weight on his new knee, and something inside gives way. A pop. A snap. Why? Because the surgeon used a non-cemented implant that requires the bone to literally grow into it over several weeks.
Oh, wow.
And the protocol in the EMR, the one you didn't read, was toe touch weight-bearing only, meaning he's only allowed to rest his toes on the floor for balance.
So you could ruin the entire multi-thousand-dollar surgery in the first 30 seconds.
You could loosen the implant. You could cause a periprosthetic fracture, which is a disaster. The surgeon dictates these protocols based on the patient's bone quality and the specific fixation method they used. Some patients are 100% weight-bearing immediately, others are 50%, others are 0.
And you have no way of knowing without reading that chart.
None. If the therapist doesn't know that specific rule before they enter the room, they are a danger to the patient. Period.
It's not just a suggestion, it's a structural limit. But the EMR isn't just about the knee, is it? It's about the whole medical history. Zan talks about connecting the dots with comorbidities. And the one that really stuck out to me was his discussion on blood thinners.
Oh, this is a huge one. Almost every single post-op knee patient is on some kind of anticoagulant, Lovenox, Xarelto, Coumadin, or even just a high-dose aspirin regimen.
And the goal there is to prevent blood clots, which seems like a good thing.
It's a very good thing. A DVT, a deep vein thrombosis, can travel to the lungs and be fatal. So preventing clots is priority number one. But the side effect is that their blood becomes, well, very thin. Their ability to clot is suppressed, and their capillaries become incredibly fragile.
So they bruise like a peach.
Bruise is almost too mild a word for it. If a therapist, not knowing this, grips the calf or the thigh with a standard firm grip, the way you normally would to help move a leg, they can leave perfect handprints that turn into massive hematomas.
Not just a little black and blue spot.
No, we're talking deep, purple-black, swollen, painful bruising just from being held. It can be alarming for the patient and their family. They think something is terribly wrong.
So how do you handle a leg you basically can't touch? What's the technique?
You have to completely change your mechanics. Zan talks about using force distribution. You never grab with your fingertips. You don't create pressure points. You scoop with the broad, flat surface of your forearm or your open palms.
Spreading the load out.
Exactly. He even mentions using sheepskin or a thick folded towel as a buffer between his hands and the patient's skin, especially when doing stretching. It's a tactile adjustment that you only know to make if you flag that medication in the chart beforehand.
It's like the difference between handling an antique vase and a football. You have to know what you're holding.
That's a perfect way to put it.
And then there's the other side of the medication coin, the pain meds. This feels like a classic catch-22. You need the meds to tolerate the therapy, but the meds make you unable to do the therapy.
It's the classic opioid fog. You have patients on oxycodone, hydrocodone, maybe some muscle relaxers like Valium. These drugs are all central nervous system depressants. So say you schedule your visit for 1 p.m. and the patient took their heavy dose at 12:30.
You walk in and they're just gone.
You might walk in and find them literally unable to keep their eyes open. They're nodding off mid-sentence. And you cannot teach a complex gait pattern or a new exercise to someone who is semi-conscious.
They're a fall risk just sitting in the chair at that point.
Absolutely. But the flip side is just as bad. If you come when the meds have completely worn off, they are in excruciating pain, guarding, and they'll refuse to move at all. And you can't blame them.
So the therapist is basically an air traffic controller trying to find a landing slot in their medication schedule.
That is exactly what it is. You have to ask, when do you take your meds? When do they kick in? When do you feel the most relief, but also the most clear-headed? You're trying to schedule your visit for that Goldilocks window, maybe 45 minutes to an hour after the dose, when the pain is dampened but the brain is still online.
But there's another layer to this med issue that Zan brings up, which I never would have thought of. It's not just the brain, it's the GI tract.
Oh, the stomach issues.
Yeah.
Constipation.
It's miserable. Opioids are notorious for paralyzing the gut. They cause severe constipation. Now, you add in the iron supplements that many patients have to take because they lost blood during surgery.
And iron is also constipating, terribly constipating and hard on the stomach. So you have a patient who is nauseous, bloated, cramping, and hasn't had a bowel movement in 4 or 5 days.
And you're the person showing up asking them to do leg lifts and abdominal bracing.
Can you imagine? It's awful. The bloating creates all this intra-abdominal pressure, making it hard to engage their core muscles. The nausea makes them dizzy. It's not just my knee hurts, it's my whole body feels like it's shutting down.
So as the therapist, you have to recognize that if a patient is refusing to move, it might not be the knee pain at all.
Right. It might be that they feel like they're going to throw up, or they're so cramped up they can't bear to tighten their stomach muscles. It's about looking at the whole system.
Which brings us to the broader point Zan makes, which I think is so important. It's never just a knee. You can't just treat the joint in isolation. He talks about how other parts of the body can completely derail the rehab.
It's the classic kinetic chain reaction of the musculoskeletal system. I mean, you have to think about it. Why did the patient need a knee replacement in the first place?
Usually osteoarthritis, right?
Right. And osteoarthritis is rarely polite enough to stay in just one joint. If they have it badly in the knee, they probably have some version of it in their lower back, their hips, or their shoulders and hands.
He specifically mentioned spinal stenosis is a big problem.
It's a huge one. If a patient has spinal stenosis, that's a narrowing of the spinal canal, they often can't stand up straight without getting terrible back or leg pain, so they walk with this permanent forward stoop.
Bent over.
Right. Now, you've just given them a brand new knee that requires full extension, full straightening out to work properly and to have a normal gait. But their back is literally forcing them to stay bent at the waist and hips.
Yeah.
They're fighting the spine to save the knee.
The two body parts are working against each other.
Completely. And you have to know that going in because your goals and exercises have to be modified. You might not achieve perfect posture, but you have to work within those limits.
And the upper body example he gave was even more practical and immediate, the walker.
This is a classic day one disaster waiting to happen. You, the therapist, show up with a standard front-wheeled walker from your car. To use it properly, you have to grip the handles and push down to offload your body weight. Simple enough.
But what if the patient has severe rheumatoid arthritis in their hands and wrists?
Exactly. Their hands might be gnarled, swollen, incredibly painful. They physically cannot bear weight through their wrists. It's agony. So now you have a patient who isn't allowed to put full weight on their leg and physically can't put weight on their hands.
They're completely stuck. They can't move.
They are stuck. And if the therapist didn't catch that rheumatoid arthritis diagnosis in the chart, the whole session is over before it even began. You've brought the wrong tool for the job.
So what's the solution? They need special equipment.
They do. They need what's called a platform walker or a gutter walker. It has these troughs or platforms that you rest your forearms in, so you bear weight through your elbows and forearms instead of your hands.
But you have to know to bring that with you.
You have to know to order it from the medical supply company or bring it from your agency's stock. You can't just conjure it out of thin air. It all comes back to that pre-game EMR review.
The amount of logistics involved here is it's amazing. And speaking of logistics, before we even get to the patient's house, Zan talks about something he calls the traffic jam. This sounded funny, but also incredibly frustrating, the reality of home health care.
It's a systemic issue, and it drives therapists crazy. On day one, especially, everyone wants to see the patient. The nurse needs to do the official admission paperwork, check the wound, go over meds. The occupational therapist wants to check bathroom safety and dressing techniques. We, the physical therapist, need to start exercises and mobility. The social worker might be checking in on their support system.
And I'm guessing you don't all carpool to the house.
Yeah, and there's no central dispatch coordinating our arrivals. So Zan describes this scenario that happens all the time. He drives 20 minutes across town to the patient's house. He pulls onto their street, and he sees the nurse's car zip into the driveway right in front of him.
And he knows, in that moment, his schedule is doomed.
He's dead in the water. The nurse's admission visit can take 45 minutes, an hour, sometimes longer. He can't just barge in while she's doing a sterile dressing change or having a sensitive conversation about medication side effects.
And you can't bill for that time, can you?
No, you can't bill for sitting in your car on the street. So you just sit there losing money, losing time, and it throws off your entire schedule for the rest of the day. Your 3 o'clock appointment is now at 3:30, and so on.
It's a literal traffic jam in the driveway.
It is, and it highlights why the EMR can also be a coordination tool. If you see a nurse is also assigned, you pick up the phone at 8 a.m. and you call them, "Hey, I'm planning to see Mrs. Jones at 10. When are you going?" It prevents that collision.
So a 5-minute phone call can save you an hour of frustration.
And improve patient care because they're not getting bombarded by 3 different clinicians back to back to back.
So let's assume the coast is clear. The nurse is left. Zan pulls up. We are now in section 2, the CSI of the home. And he starts judging the house before he even gets out of the car.
This is the exterior scan. He's looking at the terrain, the approach to the front door. Most people don't think about their driveway until they're on a walker. Is it paved? Is it smooth concrete? Or is it gravel?
I never would have thought about gravel. Why is gravel such a big deal?
Gravel is an absolute nightmare for standard walkers. The little wheels, even the skis on the back legs, they just sink into it. It creates massive rolling resistance. It's like trying to push a shopping cart through beach sand.
So a patient could get stuck.
An elderly, weakened patient might get stuck halfway to the car for their follow-up appointment. Or, even worse, they push hard, the walker legs dig in and tip forward, and down they go. It's a huge, overlooked fall risk.
And then the stairs leading up to the porch.
He's looking at the condition of the steps. Are they rotting wood? Are they uneven bricks where one is higher than the other? How high is the rise of each step? And the railing. This is my favorite part of his, professional paranoia.
What does he do?
He walks up to the porch railing, and he physically shakes it. He puts his weight on it. He pushes it. He pulls it. He stress tests it from different angles.
He's actively trying to break it.
He's trying to see if it will break under load, because a patient who loses their balance is not going to gently touch that railing, they're going to grab it and throw their full body weight onto it in a panic.
And if it's just decorative?
If that railing is just toenailed into some trim, it's going to rip right off the house. He'd rather break it himself and say, you need to fix this, than have the patient break it while they're falling 2 feet onto concrete.
That's a good rule. Break the house, save the patient. Okay, now he's inside. The interior hazard hunt. And public enemy number 1 is the throw rug.
The humble, unassuming throw rug. To a physical therapist, a throw rug is basically a landmine.
Why, though? I mean, I have rugs in my house. They seem harmless.
When you have a shuffling gait, which almost all these patients do at first, and you're pushing a walker, you don't pick your feet up very high. So the leading edge of a throw rug becomes a major trip hazard. The walker feet catch on it or your own toes catch on it.
Okay, that makes sense.
But the even worse scenario is the rug on a polished wood or tile floor. You step on the rug, your foot gets traction on the rug, but the rug itself has no traction on the floor. The whole thing slides. It's like stepping on a skateboard you didn't know was there.
But people are so attached to their rugs. It's part of the decor, you know? It ties the room together.
That's the psychological problem. You can't just walk in like a drill sergeant and say, your house is a death trap, roll all of these up immediately.
Yeah.
They get defensive. It's their home.
So what's the approach? Zan uses this demonstration trick.
The surfboard method. Yeah, it's brilliant. He'll stand on the rug in the hallway, the one leading to the bathroom, and he'll just shimmy his feet back and forth. He demonstrates how easily the rug surfs across the floor. He says, look how fast this moves with just a little push.
And that visual hits home.
It turns the abstract concept of safety into a visceral, tangible visual. Usually the patient's eyes go wide and they or their spouse will say, okay, let's roll that up and put it in the closet for a few months.
It's hard to argue with physics when you see it in action. He also brings up the issue of hoarding. And this isn't just, a bit of clutter. He describes these narrow channels.
We've all seen it to some degree in our work. Homes with stacks of newspapers, magazines, old mail, QVC purchases still in the box, all lining the hallways. It creates these canyons that are barely shoulder-width wide.
And a walker is wider than a person's shoulders.
A standard walker is about 24 inches wide. So the patient is trying to maneuver this 24-inch wide aluminum frame through an 18-inch gap between stacks of National Geographics from the 1970s.
It's not going to work.
No, the walker gets snagged. The patient twists to try and free it. They lose their balance. It's a recipe for a fall. And if they do fall in that narrow channel,
How do you even get them up?
you can't. There's no room for you to get beside them for leverage. EMS can't get a backboard or a stretcher in there. It becomes a massive extraction problem. So part of that day one assessment is a very delicate negotiation. We need to clear a runway. Just a path 3 feet wide from the bedroom to the bathroom to the kitchen, just for a few weeks.
It's about function over form for a little while.
For a little while, exactly. And then there's the living, breathing trip hazard, the pet.
Yes. The pet problem.
Dogs and cats love their owners. They've missed them. When the owner comes home from the hospital, the pet is excited, they're anxious, they want to be close, they weave between the legs, they lie down right under the recliner.
And Zan says he often doesn't know they're there until it's too late.
He tells a story about stepping backward to give a patient room and hearing a yelp. And your natural human instinct when you step on a living thing is to jump.
You recoil, yeah.
That sudden jump throws off your center of gravity. Now imagine the patient doing that. He's very strict about this. When the patient is up and moving, the dog needs to be crated or in another room with the door closed, at least for the first week or two until the patient is steady on their feet.
It's tough love for Fido, but it's necessary.
It's a temporary safety measure.
Okay, now let's talk about the cockpit. The patient's base of operations. This is usually a recliner, right?
Right. This is where the patient will spend 90% of their waking hours for the first week. Zan treats it like setting up an astronaut's command center or a pilot's cockpit. He literally sits in the chair and checks the reach zone.
And what absolutely needs to be in that zone?
The phone. This is non-negotiable. If they fall, can they reach the phone to call for help? Also, a bottle of water, some snacks, tissues, the TV remote, and their pain medications.
Why is that so important?
Because instinct is a powerful thing. If the phone rings and it's on a table across the room and instinct takes over, the patient tries to lunge for it. They forget they have a new knee. They forget the walker. They stand up too fast. Their blood pressure drops. They get dizzy and they fall.
So you have to bring the world to them.
You create a self-sufficient perimeter where they can survive for 4 hours without needing to get up if they have to. He even talks about creative solutions patients come up with, like getting a little pouch they wear around their neck for the phone, or using Velcro to stick it to the walker frame.
Whatever it takes.
Yeah.
Now, we have to talk about what's often the most dangerous room in the entire house. The bathroom.
The bathroom trap. Statistically, this is where the most falls happen for the elderly, even without surgery. After surgery, it's 10 times worse.
And Zan uses the parking a car analogy, which I thought was perfect.
It's brilliant. Most residential bathrooms, especially in older homes, are tiny. You have a toilet, a sink, and a tub jam-packed into a little space. You walk in with a walker, and now you're stuck. You literally cannot turn around.
It's like driving a Hummer into a parking spot marked compact only.
Exactly. So the patient has to do this awkward, dangerous 20-point turn. Shuffle back, shuffle forward, twist, shuffle back again. It's exhausting. And they're often doing this when they are rushing to use the toilet, which adds a layer of panic.
And the toilet itself.
Yeah.
The height is a huge factor.
It's all about the physics and biomechanics of the squat. To sit down on a standard low toilet, which might be only 14 or 15 inches high, you need 2 things. Deep knee flexion, so a lot of bending, and significant eccentric quad strength. That's the muscle's ability to lower your body slowly and under control.
And a brand new post-op knee has neither of those things.
0. They are stiff as a board, so they can't bend deep, and their quadriceps muscle is shut down or inhibited by the pain and swelling from the surgery. So what happens? They get about halfway down, the muscle just quits, and they plop.
They just drop the last few inches. The controlled crash.
Exactly. And that plop creates a massive spike in force through the new joint, which is painful. Or they're unstable and they miss the seat entirely and end up on the floor.
So what's the fix?
This is why Zan is so obsessive about either an elevated toilet seat, which clamps on top of the existing toilet, or a bedside commode frame that goes over it. It raises the target by 4 or 5 inches. That small difference in height makes it mechanically possible to sit down safely.
It's providing dignity through engineering.
Absolutely.
Okay, so the house is secure, the rugs are gone, the dog is crated, the toilet is raised. Now the real interaction starts.
Yeah.
Section 3. The interrogation. The subjective assessment. But Zan doesn't just ask a list of questions, he plays a character.
The Columbo method, I love this description.
For our younger listeners, Columbo was a famous TV detective who wore a rumpled trench coat and acted kind of confused and bumbling, but he was secretly a genius who was always observing everything.
Right. Zan uses this persona to test the patient's mental status. He needs to know if the patient is alert and oriented, ×3. That's to person, place, and time. But he doesn't want to sound like a doctor asking, do you know who you are? Do you know where you are?
That sounds clinical and scary. It makes them feel like you think they have dementia or something.
Exactly. It puts them on the defensive. So he acts ignorant to get the information. He'll be chatting about the day and say, boy, it's been such a long week. Is today Monday or is it Tuesday? I can't even remember anymore.
He baits them into giving him the answer.
He does. And if the patient says, oh, honey, it's Tuesday, you need to get a better watch, then boom, he knows they're oriented to time. He'll look around and say, this is a lovely house. How long have you lived here? If they give a coherent answer about buying it in 82, he knows they're oriented to place.
He gathers all the data without ever formally testing them. It preserves their dignity.
It's brilliant social engineering, really. It's about building rapport while still getting the objective data you need.
That's fascinating. Now let's talk about pain. This is the big one. Zan has a very clear philosophy here that he drills into people. Monday's 3 is Tuesday's 3. What does he mean by that?
He means you have to accept the principle of subjectivity. Pain is invisible. You can't measure it with a ruler or a blood test. So if a patient tells you their pain is a 10 out of 10, even if they are sitting there smiling and eating a sandwich, you have to document it as a 10.
You can't argue with their perception.
You can't. You can note the discrepancy in your documentation. Patient reports 10-10 pain, observed to be smiling and conversing, but you cannot change their reported number. It's their experience.
But isn't that useless data if it doesn't match what you're seeing?
Not if you look for trends. That's the absolute key. Zan doesn't care about the single absolute number as much as he cares about the direction the number is going. If the pain was a 6 yesterday and it's a 4 today, we are winning. The therapy is working, the inflammation is calming down.
And if it goes the other way?
If it was a 4 yesterday and it's an 8 today, we have a problem. Did they overdo it? Is there an infection starting? It's the trend over time that tells the real story.
He also mentioned the zero pain red flag.
Yes. If he walks in on day one and the patient says, I have zero pain, he doesn't high-five them. He gets suspicious.
Why? Zero pain sounds like the ultimate goal.
Because you just had your bones sawed off and a metal and plastic implant hammered into place. Zero pain is not a physiologically normal response on day 1 or 2. It usually means one of two things. They are absolutely blasted out of their minds on painkillers, or they still have a nerve block from the surgery that hasn't worn off yet.
So it's an artificial zero.
It's a temporary artificial zero. He knows that reality is coming for them probably in about 12 hours when that block wears off, and he needs to prepare them for that.
The other part of the pain conversation that I found so profound was creating the aha moment for the patient, connecting pain to activity.
This is the education piece, and it's so powerful. Patients often see pain as this random, scary weather system that just defends on them. It just hurts today. Zan's job is to help them link cause and effect. He asks, so tell me what you did this morning before I got here.
Well, I walked to the mailbox and back.
Okay, so your knee hurts because you walked to the mailbox. It seems so simple, but for the patient, it's a revelation.
It empowers them. It means the pain isn't some random complication. It's the cost of doing business. It's the price of progress.
Exactly. It reframes the pain from something is wrong with me to I did work and this is the result of that work. That shift in mindset reduces fear and anxiety, which in turn can actually help reduce the perception of pain.
Before we get to the physical exam, there's one last dark corner of the subjective assessment to shine a light on: the social safety net. This is what Zan calls the 5 p.m. to 8 a.m. gap.
This is the scary part of the job. You'll have patients who insist, oh yes, I have help, my daughter comes by. But as a therapist, you have to drill down on that. Okay, when does she come by? And you find out the daughter stops by before work at 8 a.m. to make breakfast, and then again after work at 5 p.m. to make dinner.
So they are completely alone for 12 hours overnight.
And often for 9 hours during the day. The question Zan asks the family and himself is brutally direct. If you slide out of that chair onto the floor at 2 a.m. while trying to get to the bathroom, who is going to pick you up?
And if the answer is nobody,
If the answer is nobody, I'll have to wait until my daughter gets here in the morning. That is a critical safety failure. That might trigger a call to the surgeon or the social worker to get a temporary night aid or even a transfer to a subacute rehab facility. You cannot leave a high fall risk patient alone overnight.
it's a sobering reality check.
Yeah.
Okay, section 4, the physical exam, the objective assessment. This is the hands-on stuff.
It always starts with vitals.
Yeah.
Blood pressure, heart rate, oxygen saturation, temperature, every single visit.
Why is this so vital? Pun intended.
Because things can go wrong very, very fast. A temperature spike of just 2 degrees might be the only early sign of a burgeoning infection in the joint. A sudden drop in oxygen saturation could be a pulmonary embolism, a blood clot that's traveled to the lung. Zan says he's caught these things before the patient even feels sick.
It's early detection.
It's a safety net. Then he looks at the knee itself, the incision. And this brings us to the most controversial, heated, and absolutely critical topic in the entire lecture: the pillow controversy.
This is the hill that every physical therapist will die on, isn't it?
This is our Alamo. Do not put a pillow directly under your knee.
But wait a minute. I'm the patient. My knee is swollen. It's throbbing. It feels like it's going to explode.
Yeah.
When I bend it just a little and put a soft pillow right under it, the pain goes away. It feels so much better. Why are you being so cruel as to take that away from me?
I know, it sounds heartless, it feels counterintuitive, but here is the mechanism behind it. The knee joint capsule, that's the watertight sleeve of ligaments around the joint, has the most internal volume, the most space, when it is bent at about 30 degrees.
Okay.
So when the knee is full of swelling and fluid, bending it slightly relieves the pressure inside. It literally makes more room for the fluid, which is why it feels good.
So it's a relief valve. That makes sense.
Right. But here's the deadly trap. If you leave it in that comfortable bent position for hours and hours, day after day, the posterior capsule, the tissue in the back of the knee, and the hamstring muscles begin to physically shorten. Scar tissue starts to lay down in that shortened position.
That gets stuck like that. A contracture.
A flexion contracture. And if that sets in, you may never be able to fully straighten your leg again. You will walk with a permanent limp. Your leg will functionally be shorter than the other one. You will essentially be walking on a bent peg for the rest of your life.
That sounds absolutely horrific.
It is, and it's incredibly difficult, sometimes impossible to fix once it's established. It is much, much easier to get bending or flexion back later than it is to get that last bit of straightening or extension back. So Zan enforces the rule with no exceptions. The leg must be propped up straight when resting.
And he does that by putting the roll under the ankle, right, not the knee.
Exactly. An ankle prop. You put a pillow or a rolled up towel under the ankle and heel. This creates a bridge. The heel is on the roll, the thigh is on the bed, and the knee hangs in space in the middle. Gravity then becomes your friend, gently pushing the knee straight.
Which hurts.
It's uncomfortable, it aches, it can be miserable for 20 minutes, but it is stretching that posterior capsule. It is preventing the contracture. It is the single most important thing a patient can do for a good long-term outcome. Short-term pain for long-term gain.
Wow. Moving from that kind of torture to a tighter kind of torture, the TED hose,
Right.
same as white compression stockings.
The struggle is real. These things are incredibly tight for a reason, to prevent blood from pooling and clotting in the calves, but putting them on a swollen, painful post-operative leg is like trying to stuff a sausage back into its casing.
Zan has a very specific timing tip here.
The morning rule. It's non-negotiable. You have to put the TED hose on before the patient gets out of bed for the day, before their feet even touch the floor.
Why does the timing matter so much?
It's all about gravity. Overnight, while they're lying flat, the fluid naturally drains out of the legs. The leg is the skinniest it will be all day at 7 a.m. The moment they stand up and walk to the bathroom, gravity pulls all that fluid right back down into the lower leg. The calf and ankle swell up.
And if you try to put the stocking on after breakfast?
It's too late. The leg is too big to fit into the stocking. It's a battle you will lose, so it has to be the first thing you do in the morning.
It's a race against the swelling. Okay, let's talk about ice. Cryotherapy.
Zan says he sees the whole spectrum, everything from $300 circulating ice water machines to Ziploc bags full of ice cubes. But he has a specific beef with the classic home remedy, the bag of frozen vegetables.
What? I thought frozen peas were the gold standard. They mold perfectly to the shape of the knee.
They do mold well, yes. But here is the physics problem. To be effective, therapeutic icing needs to lower the temperature of the tissue deep inside the knee, down to the joint capsule, and the bone to slow down the inflammatory cascade and the cellular metabolism.
And a bag of peas doesn't do that.
A bag of peas thaws way too fast. They are small, separate units with a lot of surface area. They turn into mushy room temperature soup in about 10 or 15 minutes. That is not enough time to drive the cold deep into the tissue. It cools the skin, but it doesn't effectively cool the joint itself.
You need a solid block of ice, something with more mass.
You need thermal mass. It needs to hold the cold for a long time. And that brings us to the hero of this entire story, the frozen margarita lady.
The absolute hero of the episode.
This 80-year-old patient, Zan, walks in, and she's icing her knee with these big bags of frozen margarita mix. And he's about to correct her, but then he thinks about it. Why did this work better than peas?
Why did it?
Alcohol has a lower freezing point than water, so the mix stays slushy but very, very cold for a long time. It's a dense liquid mass, it molds to the knee perfectly, and it held the cold long enough to be genuinely therapeutic.
Plus, there's a built-in reward system.
Exactly. She told Zan with a twinkle in her eye, "When it melts, I drink it." It's brilliant behavioral psychology. She turned a chore into a party. It just speaks to the creativity and resilience patients have.
I love her. I want to be her when I grow up. Okay, briefly on sensation. Zan checks for numbness. Why is that important?
It's mainly for patient education and reassurance. He warns patients about the numb patch. When the surgeon makes that long incision down the front of the knee, they inevitably have to cut through some of the tiny cutaneous nerves that supply the skin on the outside or lateral part of the knee.
So that patch of skin is just dead.
It's numb. It feels like leather to the touch. Patients freak out. They touch it and feel nothing, and they think, my leg is dead, the surgery went wrong. Zan has to reassure them. This is normal. It's an expected consequence of the incision. The feeling might shrink over a year, but you might always have a numb spot right there. It doesn't affect the muscle or the function of the joint.
And finally, he watches them move. The gait analysis. He mentions the step 2 pattern as the starting point.
This is walking 101 for post-op patients. A normal person walks with the step-through pattern. Left foot passes the right foot passes the left. But a post-op patient is too weak and unstable for that. So they start with step 2.
How does that work?
You move the walker forward a few inches. Then you step with the bad surgical leg. Then you bring the good leg up to the bad leg so they're side by side. Stop. Repeat.
It's very slow and deliberate.
It's safe. It keeps their center of gravity inside their base of support at all times. The goal on day one isn't speed, it's not falling. He also spent a lot of time correcting walker misuse. You'd be surprised how many people just pick up the walker and carry it like a
Get
handbag.
carried in the air.
Yes, they lift it completely off the ground and stumble forward with it. They aren't putting any weight through it. It's not helping them at all. Zan has to stop them and say, no, no, push down on the handles, let the walker do the work. That's what it's for.
Okay, we've gathered all the clues, we've secured the scene, we've done the physical exam. Now we're in section 5, the scorecard. How do we actually measure success? Zan talks about the shift to PROMS, patient-reported outcome measures.
These are standardized surveys that turn this objective assessment into objective trackable data, things like the KOS, which is the knee injury and osteoarthritis outcome score, or the WMANAC. But he warns against one specific test that is popular in other areas of orthopedics, the LFS.
The lower extremity functional scale. Why does he hate the LAFS for knee replacements?
It's because of something called the ceiling effect. The LEFS was designed for younger, more active patients. It asks questions about very high-level activities. Do you have difficulty running on uneven ground? Do you have difficulty hopping on one leg? Do you have difficulty making sharp, quick turns?
Well, obviously, if I had major surgery yesterday, the answer to all of those is I can't do that at all.
Exactly. So you get a score of 0, and then 2 weeks later, when you see the therapist again, still 0. And 4 weeks later, still 0. You might be walking much better around your house, you might be climbing stairs, you might be feeling great, but the test doesn't show it because you still can't hop.
So the test is telling you you're failing, even when you're actually succeeding in your daily life.
Precisely. It's demoralizing for the patient, and it looks terrible to the insurance company who's paying for the therapy. You need a test that measures relevant progress, like the timed up and go test, or TUG.
What is that?
It's simple. You time how long it takes a patient to stand up from a chair, walk 10 feet, turn around, walk back, and sit down. That measures exactly what they need to do to live independently. If it took them 30 seconds on day 1 and 20 seconds 2 weeks later, that's real measurable progress.
And finally, the assessment part of the SOAP note. This is where the therapist gives their professional opinion, right? The rehab potential.
This is the therapist's poker bet. They're looking at the whole picture, the supportive spouse, the flat driveway with no gravel, the patient's good motivation, their strong heart, and they're making a prediction. Does this patient have excellent potential for recovery at home? Or does the clutter, the cognitive issues, and the lack of help make their potential poor?
And that decision has real consequences.
It determines everything. It decides if they can safely stay at home or if the therapist needs to recommend they go to a skilled nursing facility for more intensive care.
We're in the home stretch now. Section 6, the game plan. The P in SOAP.
This is where the detective becomes the coach. Now that we know all the facts, we need to create a plan. And it starts with goals. They need to be SMART goals.
Specific, measurable, attainable, relevant, and time-based.
That's it. A bad goal is, patient will get stronger. What does that even mean? How do you measure it? A good goal is, patient will perform an independent sit-to-stand transfer from an 18-inch surface within 2 weeks in order to allow for bathroom independence.
It paints a clear picture of what success looks like.
And it holds everyone accountable, the patient and the therapist. We know what we're aiming for.
And what about the exercise prescription itself? Zan has a very specific mantra. Frequency over intensity.
This is the grease the groove concept. It's huge for post-up joints. He prescribes exercises 4, 5, even 6 times a day.
Wow, that sounds exhausting.
But he keeps the repetitions low, maybe just 10 reps of each exercise. The idea is to combat static positioning. If you do a huge hard workout for an hour and then you go sit in the recliner for 8 hours straight, the knee turns to cement. Stiffness sets in.
The Tin Man effect. You rust in place.
That's a perfect way to describe it. But if you do just 5 minutes of gentle movement every 2 hours, you keep the synovial fluid, the joint's natural lubricant, circulating. You keep the joint lubricated. You prevent that stiffening from ever taking hold. It's so much better to snack on exercise all day than to binge on it just once.
And to make sure the patients actually do the exercises right, he uses the show me method.
He never just hands out a sheet of paper with stick figures on it. Stick figures are confusing. He makes the patient perform each exercise while he watches and corrects their form. And then, here's the pro tip of the century. He uses the patient's own smartphone to film them doing the exercise correctly.
Oh, that's brilliant.
It is. Because at 8 p.m. that night, when they're tired and they forget how to do a quad set, they don't have to guess. They can just play the video and watch themselves doing it perfectly. It boosts confidence and ensures compliance.
And finally, the golden rule of all healthcare: documentation.
If it isn't documented, it did not happen. It's your legal shield, first and foremost, but it's also the story of the patient's recovery. It's the only way the next therapist or the doctor knows what happened today.
So we've finally survived day one. We navigated the gravel driveway, we dodged the nurse, we rolled up the rugs, we crated the dog, raised the toilet, iced with margaritas, and set our goals. It is an absolutely exhausting amount of detail.
It is, but think about the alternative. If you miss the rug, they fall and break a hip. If you miss the blood thinners, you cause a massive hematoma. If you miss the pillow under the knee, they get a permanent contracture. This day one deep dive is what separates a successful, smooth recovery from an absolute nightmare.
It really turns the patient from a passive victim of surgery into an active participant in their own rescue. They aren't just healing, they are actively working a plan.
And honestly, the lesson I'm taking away from all this is the resilience factor. I just keep coming back to the margarita lady.
Absolutely. You can have the most perfect evidence-based medical protocol in the world, but her innovative spirit seeing cocktail mixer as a potential medical device, that's what got her through.
It really suggests that while the perfect home setup with all the right equipment matters, maybe the patient's willingness to adapt, to laugh, to innovate, to endure the discomfort of that ankle roll because they trust the process is the real X factor for success.
Well, on that note, I think I'm going to go home, check my porch railing for stability, and maybe blend a margarita. Yeah, just for preventative icing purposes.
Can't be too careful. It's all about risk management.
Thanks for joining us on the deep dive. We'll see you next time.